So I think at this point, the main tool that we have there is TDM1, which it should be, it has an overall survival advantage. It should be a clear standard of care for all of those patients, even if they have only a tiny bit of residual disease. And even if their residual disease has become HER2 negative at the time of surgery, they still benefit from TDM1 in the KATHERINE trial. So I think TDM1 is the clearly established standard across the board for that population at this point. There are 2 trials that will tell us if we can add on to or do better than TDM1. So the Compass HER2 RD trial is looking at TDM1 plus or minus tucatinib. And if that trial is positive, then I absolutely think we should add tucatinib for some of these patients. We know that doublet HER2 blockade is better than singlet HER2 blockade in a lot of settings. So I think there's a lot of rationale to believe that adding the HER2 TKI to the ADC will be effective. And in addition, we know that tucatinib is especially active in the CNS, which is a place where TDM1 didn't look as good in the KATHERINE trial. It definitely reduced recurrences overall, but it did not reduce CNS recurrences. So, I think the potential to solve both of those, to solve 2 problems with the addition of tucatinib will be good if that trial turns out to be positive. And then there's the DESTINY-Breast05 trial that's looking at a direct comparison head-to-head of TDM1 versus TDXD in this setting. We know that TDXD outperforms TDM1 very easily in the metastatic setting. It seems reasonably likely that we'll see it outperform TDM1 in the residual disease setting as well, although we don't know yet. So I think for now, TDM1 is the clear standard, but perhaps in the future, we'll be either adding tucatinib to it or swapping it out for TDXD, depending on the results of those ongoing trials.